Good afternoon, everyone. The topic for today's topic of my study is to assess the effect of administration of high dose of IV methylprednisolone in pediatric optic neuritis. So, as we all know, pediatric optic neuritis is a more challenging uh, entity as compared to the adults, given the delayed presentation of the patients. The causes can range from demyelinating causes to para-infectious, infectious, and non-infectious causes. So, in our study, we have included patients which presented to us with the history of with history corresponding to the optic neuritis, and then we've gone ahead and diagnosed them with optic neuritis, and then followed up with our investigations and clinical assessments to give a definitive diagnosis. The investigations, our ophthalmic examinations was comprised of BCVA, contrast sensitivity, color vision, fundoscopic examination. Investigations comprised of neuro relevant laboratory workup, neuroimaging like MRI brain orbits and spine, and serological tests comprising of MOG antibodies and anti-aquaporin 4 antibodies. The final clinical diagnosis was made on the basis of the presence or absence of RAPD, dyschromatopsia, optic disc edema, visual field defects, and abnormal visual VEPs. We have six representative cases. So in the first case that presented to us, we can note that there was a diminution of vision in the left eye with pain on ocular movements. The visual acuity was hand movements with presence of RAPD. Disc photo revealed the hyperemic left disc with subnormal VEP responses. MRI was done for the patient, which showed enhancement of the optic nerve sheath. However, the rest of the brain was normal. Hence, this patient was diagnosed to have isolated pediatric optic neuritis. This was a similar case, but involving both the eyes. The MRI here also gave us optic nerve sheath enhancement, but a normal brain, and hence the same diagnosis was made for this patient as well. In the third case, we had bilateral retrobulbar neuritis, and this patient reported to be MOG and NMO antibody positive with MRI spine was also done for this patient, showing mild prominence in D6 to D8, and a diagnosis of ADEM-like acquired demyelinating syndrome was made. In the fourth case presenting to us, it was a similar case, but also had a history of iron deficiency anemia, and an isolated pediatric ophthalmic optic neuritis was made. The diagnosis was that. In the fifth patient, we had both eyes severe vision loss with multiple T2 hypertense lesions in both thalami. So after 1 month follow-up, after we have administered IVMP, according to the ONTT trial, these were the final visual acuities of the patients. We can see that the sixth patient, the last patient, did not recover as they did not refuse to enroll in IVMP. So these were the results of my studies. Most patients were male, 17% of them were females. About 80% of the patient presented with bilateral optic neuritis. In the MRI, in case 3 and case 5, a diagnosis of ADEM-like demyelinating disease was made. According to the ONTT protocol, IVMP and oral prednisolone was started for the patients, and we could see significant visual improvement. The take-home message for this study would be that a high clinical suspicion and a prompt and an apt management is crucial for the favorable visual outcome. It's important that we also include our neurologists and pediatric colleagues for the more comprehensive approach, and we must take into account that IVMP can have some systemic side effects as well. So we have to do all the administration and a close monitoring. Saving a child's sight is not just restoring vision, but giving them a world of limitless possibilities and dreams. Therefore, pediatric optic neuritis demands a more meticulous approach. Thank you.
Thank you. Was there any difference in your management approach in the patients that were NMO-MOG positive as
Yes,
compared
sir.
to the other?
We had also started them on mycophenolate and given some immunomodulators and
Immunosuppressants.
immunosuppressants.
Immunomodulators are
Suppressants, sir.
contraindicated in
My bad.
NMO-MOG. Okay, fair enough. So yeah, obviously the management of NMO-MOG is different and requires more aggression. In fact, that's a very, particularly NMO is a poor prognosticating factor for outcomes.
So, since we're dealing with pediatric patients, did you consider malingering as one of the causes in any of the patients? I mean, since
So,
many of them.
most patients did show signs of disc edema, so malingering was a little less likely. And we also the imaging studies showed us changes. Therefore,
So the point I'm
malingering.
trying to make is that when the child presents with bilateral severe visual loss and there are no ocular findings, we actually like before rushing to the other things, if we as a protocol also just look for that also. It's a different
Yes, sir.
subset. I'm just
So in a
this is just
retrobulbar case, due to the
yeah,
paucity of
absolutely,
symptoms.
absolutely.
Yes.
Thank you very much.